share my screen here. There we go. I'm Dr. Lorna Stewart, and I am the president and owner of Lorna Stewart, MD and Associates. And I have a brand new primary care office that opened here in Naples, and I'm so excited to be here. But first, I would like to introduce Dr. Lisa Larkin. She is one of my associates, and she is the brains behind Ms.Medicine, and we're so excited to have her here as well from Cincinnati, Ohio. Dr. Larkin.
Thank you. I'm so happy to be here as well. Thank you for the nice introduction, Lorna, and I'm looking forward to your presentation, and I'm happy to have the opportunity to talk to you all today from Cincinnati, Ohio, where it's 5 degrees. So I'm very jealous of you all right now down in Naples.
So Dr. Larkin, oops, my slide, I am so sorry, it's advancing without me. Sorry. Let's go back here. Dr. Larkin is the founder and CEO of Ms.Medicine and the founder and president of Lisa Larkin, MD and Associates. And she trained at Yale and the University of Chicago. And she is a women's health internist, specializes in menopause and sexual medicine, and a physician and consumer educator. She's been practicing for over 30 years. And I'm so excited to be able to partner with her in opening my office here in Naples. I'm the first satellite office here in Naples, but up in Chile, Ohio, Dr. Larkin has 5 other satellite offices. She is in Cincinnati, has 2 offices there, and there's also one in Dayton, Ohio, one in Michigan, and one in Virginia. But we're super excited to be here in Naples, where it's nice and cold, nice and warm for all you guys who are up there in the snow. But Ms.Medicine is raising the standard for healthcare for women, and we're so excited to finally get to shed some light on heart disease and women. So first, a little bit about me. I was born and raised here in Naples, Florida. I attended medical school and undergrad at the FSU College of Medicine, and I am family medicine board certified and have 12.5 years of hospitalist experience. So I'm the founder and president of Lorna Stewart, MD and Associates, which is our first Ms.Medicine affiliate here in Florida. And I do have special interests in geriatric and women's medicine. So on to our program here today. I'm going to talk a little bit about women and heart disease and the gender discrepancies in care. Just to give you a little bit of history, Dr. William Heberden, all the way back in 1768, was commenting on chest pain. And what he decided to say is that he saw about 100 patients and only 3 were women. All of the rest were men, and they were in their 50s. So looking back even to the 1700s, this was believed to be a male dominant symptom, and it was never considered that diseases may manifest differently in men and women. Let's fast forward now to the 1960s. The American Heart Association is still perpetuating that belief and had a conference for women in heart disease on how can I help my husband cope better with heart disease. They also put out their diet plan and pamphlet, The Way to a Man's Heart. So even 200 years later, we are still focusing on chest pain and heart disease as a male dominant issue. So healthcare throughout history has been made for men by men, and unfortunately women have been seen as just smaller men with only differences in reproductive organs and hormones. And often our women's symptoms were attributed to hysteria, and we've been excluded from those clinical trials and research, and never considered that women might manifest and recover from diseases differently or metabolize medications differently than men. And just a little cartoon here talking about studies with fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but we never considered using women as subjects. Never really occurred to anybody. So here we are, and fast forwarding another 30 years, the New England Journal of Medicine is starting to recognize that there are some issues with heart disease and recognizing that women can be affected. But they highlighted the Yentle Syndrome, which is an article that commented on the heroine of Isaac Singer's short story. This short story was brought to life by Barbara Streisand in the movie Yentle in 1983. But to explain that a little bit more, the story is about a woman who had to disguise herself as a man to attend school to study the Talmud. And just even the first paragraph of this article from the New England Journal of Medicine, that women being different from men meant being second class and less equal. And it's just sad but not surprising that women have all too often been treated less than equally in social relations, political endeavors, business, education, research, and most importantly, healthcare. The Yentle syndrome kind of highlights that the male normal is the global gold standard, which we all know now not to be necessarily true, but women were forced to normalize to the male standard to be recognized. And even just discussing chest pain, which is angina, typical is the male symptom and atypical is the female symptom, inherent in the inherent bias in the language that's used. So finally, fast forwarding 20 years later, we're starting to finally make some progress here. The American Heart Association is recognizing that the female heart is vulnerable to cardiovascular disease, and they're putting out guidelines for the prevention of cardiovascular disease in women. So it only took until 2010 and 2011 for us to finally start making some progress. And so some of the first changes that we've seen are acknowledging that heart disease does occur in women, but it's still skewed and limited in perception. It still felt, even now, that women have other higher health priorities and myths and misconceptions. So some of these myths that are frequently out there is that breast cancer is the #1 killer of women. And a lot of people are surprised to find out that that is not the case. It is actually heart disease. They may feel that they don't have any symptoms or minimize their symptoms, which women frequently do. People frequently think that they're too young to be experiencing a heart attack, or that because heart disease may or may not run in their family, it's just out of their hands, so they don't need to make any effort to reduce their risk of having heart disease, which is completely untrue. This slide here has a lot of good information on it and really is quite eye-opening. Looking at the statistics from the year 2013 of the total deaths of the women in the United States, of 1.2 million deaths, almost 400,000 were due to cardiovascular disease, which really is a staggering number. And comparatively speaking, breast cancer was a little over 40,000. Now, not to minimize breast cancer or lung cancer or chronic lung disease, they are all very important. I just think that we can do a much better job. And this slide actually kind of brings to light that we are doing a fantastic job getting the word out for breast cancer, but we need to do a better job for cardiovascular disease. And I think a lot of lives can be saved if we can get the word out and be educated and take matters into our own hands. So these are some facts regarding heart disease in women, which may be quite surprising to some people, that coronary artery disease is the #1 killer of women in America. And 1 in 4 women who die in the United States each year die from heart disease. It causes almost twice as many deaths among women as all forms of cancer combined, which is actually quite surprising to see the statistics. More than 1 in 3 female adults in the United States has some or other form of cardiovascular disease. And females represent more than half of the people who die from cardiovascular disease, and 64% of women who die suddenly of coronary disease never even had any symptoms. So here we are, the next wave. We're finally making some progress, but we need to build awareness of the differences between men and women regarding heart disease. Now, this slide has a lot of really, really good information, and this is really some of the take-home points that I'd like to bring to your attention. On the right-hand side of the slide, there are 7 of the traditional risk factors, and actually there's 2 risk factors that are missing. Looking at the very bottom, family history, gender, and age. Those are your 3 risk factors that can't be changed. They can't be modified. But you do need to be aware that even with a family history of heart disease, it can increase your risk twofold for heart disease in both men and women. So it is important to know about those risk factors that can't be modified, but look at all of the things that we can do to reduce our risk of heart disease. Starting at the top, hyperlipidemia, which is high cholesterol. In women, a lot of women don't realize that after we go through menopause, our triglycerides go up, our LDL goes up, and our HDL goes down. Those are all going in the wrong direction. And so it makes it harder for women to achieve their cholesterol goals. So that just means that we may have to work a little bit harder, but we need to be aware. Also, for women older than 75, 80% of women older than 75 have high blood pressure, but only about 30% have adequate control. So we can definitely do better to improve that risk factor. Diabetes has a 45% higher risk of heart disease. Smoking has a 25% higher risk of heart disease. These are all things that we have control of. Obesity has a higher risk of heart disease, especially in women compared to men, 64% versus 46% in men. And also, statistically, women have a higher prevalence of inactivity, and 25% of US women are not getting enough exercise. So just looking at the right-hand side of this slide, these are all things that we can do, and these are all things that we can modify. I also want to bring to your attention some new and emerging risk factors. Surprisingly, autoimmune diseases can increase your risk of heart disease, including lupus and rheumatoid arthritis. A lot of women don't recognize that that can increase your risks. Also, pregnancy increases those risks of gestational diabetes and high blood pressure in pregnancy, both increasing your risk of heart disease in the future. Early menopause can increase your risk of heart disease, again, because of some of those changes that occur as we go through menopause. And also depression is more prevalent in women and can double the risk of heart disease. So heart attack presentation, these are super, super important slides because this is the education that we need as women to be on the lookout for those potential atypical signs of a heart attack. And women having heart attacks, they may present with the classic symptoms that are similar to a male, including that heaviness in the chest. The left arm feels numb or painful, jaw pain, sweating, nausea, shortness of breath. That's a classic heart attack symptom. But we as women also need to be aware that it can present as nausea or indigestion. Sometimes belching is common. Extreme fatigue, weakness or dizziness, loss of appetite, coughing, heart palpitations, and back pain. And looking at this list, we all go, wow, that sometimes happens to me all the time. But we need to just be aware that if these symptoms are happening and it's not going away, you need to consider that it may not be what you think it is, and to seek medical attention as quickly as possible. Symptoms for women can occur suddenly, or they can develop over hours, days, or weeks. So don't just assume that this is going to happen all of a sudden. It can happen very slowly, and we need to pay attention to our bodies. women having heart attacks, they may attribute those symptoms to other factors. They may be uninformed or ignoring those symptoms, or they may be reluctant to seek medical attention. And all of those things combined lead to women presenting later in the course of a heart attack, which also leads to permanent damage and even death because that presentation to medical care is delayed. So just to summarize a little bit, women tend to be older at their initial presentation for a heart attack or initial presentation for symptoms of heart disease. They are more likely to die in the first year after their first heart attack, unfortunately. They tend to present sicker with a heart attack, and that's mainly because we tend to ignore those symptoms, kind of press on and keep on going and not pay attention to what really is going on, which causes that later presentation for a heart attack. And that leads to further complications and, unfortunately, a higher morbidity. So we can do better. Unfortunately, right now we are failing, but we are here and you all are here. And I'm hoping that by being educated, we can get the word out. But we all need to be aware that women do have a higher morbidity when it comes to heart disease. They delay presentation and, unfortunately, have fewer revascularizations. Revascularization is more commonly known as a heart catheterization or a stent placement to open up those blocked arteries. So women are getting fewer of those. They're getting less cardiac rehab. They're getting less intense medications. They're using less use of gender-specific guidelines and inadequate identification of women at risk. And we are still also not being included in research. So prevention is key. This is what comes into play here when you meet with your primary care physician, and you need to be forming that relationship and partnership with your primary care doctor. But these are the things that we all need to be aware of and that we all need to work on, knowing your blood pressure and keeping it under control. Exercising regularly, 30 minutes a day, at least 3 times a week is a good place to start. No smoking, getting tested for diabetes. And if you have diabetes, keeping those blood sugars under control, and being educated and knowing your cholesterol and triglyceride levels and keeping those under control as well. Eating lots of fruits and vegetables, following a healthy diet, and maintaining a healthy weight. So to summarize, unfortunately, coronary artery disease is by far the biggest health risk for women. And I hope in this discussion, you have learned some things and know what to look for, because awareness is still less than it needs to be. But we can take this by the reins, educate our friends, get out there, and prevention can reduce your risks. So there's all those risk factors that are modifiable, and it's time to make sure that you see your primary care doctor regularly and that you get all appropriate screening, tests, and blood work. So thank you so much for your attention. I appreciate the invitation to speak with you this morning. Please check out my website at lornastewartmd.com and follow me on social media. And I would absolutely love for you to call my office and schedule a complimentary meet and greet. And I'd love to meet every single one of you. So thank you so much.
So Lorna, that was a terrific talk. Thank you very much. If it's okay, everyone, I'm going to switch gears and share my screen now. And we'll jump into the second part of this. Let's see. Okay, let's see, share. Okay, I think everyone can see my screen, and let me just make sure I can advance. All right. Okay, great. Well, first of all, I'd like to start by saying, Dr. Stewart, that was a terrific presentation. And I'll tell all of you that I am over the moon excited to have Dr. Stewart as my Ms. Medicine partner, really, in Naples. I, as you heard, am a women's health internist. I've been practicing in Cincinnati, Ohio for 30 years. And I have a large number of my patients who actually are snowbirds and who are in Naples for the winter. And so being able to have a partner that I respect so much and to collaborate with my existing patients who actually winter in Naples is a huge advantage for me and for providing really the kind of care that I want them to have. Because again, you know, distance makes it hard. Telemedicine these days has been helpful, but there's no question that in-person care and good quality care is so important to the health of my patients. And I'm thrilled to have Dr. Stewart as part of the Ms. Medicine family now. And I would say I'm really excited to be leaving snowy Cincinnati this weekend to come down and join her for a few events on Monday and Tuesday. I have not seen her beautiful office yet. I've only seen pictures, and I'm really excited to be with her in person and to get out of the snow. Okay, so I'm going to switch gears from heart disease and go to breast cancer, although at the end I'm going to pull in a little bit about hormone therapy and heart disease. And I'll set the stage and just tell you that, you know, again, I'll say again, I've been practicing as a women's health internist for 30 years. And what I would tell you is I launched Ms. Medicine because over 30 years, I really have seen that the unmet medical needs of women just continue to be neglected, and that there is incredible need for us, not just in heart disease, but in breast health and cancer survivorship. I can go into many, many things, menopause management, sexual health. Women are just frankly getting inadequate care, completely inadequate care. And there's really many reasons for that. But it is my mission now, for what I say is the last 10 to 15 years of my professional career, to really try to make a substantial impact on the care of women. And Ms. Medicine is about forming a network of high quality primary care providers who specialize in women's health to provide better care to women. And it's better care in terms of appropriate risk assessment and screening for cardiovascular disease. But you'll learn that, and I'll tell you why breast cancer is my other passion. It's really that we're not doing enough in breast health. And Ms. Medicine practices are really trying to make an impact on doing a better job in risk assessment and prevention strategies for breast cancer. So everyone on the call and every woman worries about breast cancer. Certainly I hear this day in and day out. And as Dr. Stewart presented, though, there's a misconception. Women worry about breast cancer, but of course you saw that you know, there's 40,000 deaths of breast cancer a year compared to almost 400,000 of cardiovascular disease. So although, don't get me wrong, breast cancer is very, very important, we have to make sure we're doing balanced education and making sure that women are also focused on cardiovascular disease. But breast cancer is the most common cancer in women, although lung cancer has a higher mortality, as you saw on Dr. Stewart's slide, about 70,000 per year compared to 40. But breast cancer, the numbers are very high. And most women know this statistic, right? 1 in 8. It's a terrifying statistic that of the, you know, I don't know, 20 plus of you on the call, I can't see exactly how many are on right now, but, you know, there's no question that several of you on the call have had breast cancer. And that's a very high number. And this average lifetime risk of developing breast cancer of 12% is really, really high, right? It's the reason that women are fearful of this. And as we said, there's about 300,000 new cases of breast cancer per year and about 40,000 deaths. One of the things that's so wonderful is that we are doing a better job treating breast cancer, and there are more and more survivors. So if you do the math, the growth of the breast cancer survivor population is about 250,000 women are being diagnosed but are surviving with breast cancer, which is growing into this breast cancer survivor population, which is now 3.3 million and growing. And I can tell you, with Ms. Medicine and what I do in practice is I take care of a lot of breast cancer survivors. And if you're a primary care provider, you're taking care of a lot of breast cancer survivors. And I can tell you that breast cancer survivors are an area that are getting really inferior care in a lot of ways. And we can talk about that at the end. So we all know that, everyone knows someone that's been diagnosed with breast cancer if you haven't had breast cancer yourself. And you can see here, we talk about, there's an increasing incidence as you age. But the majority of women are diagnosed between 55 and 64. And this is one of the reasons that it's on everybody's mind, because young women 55 to 64, it's often before they have heart disease. And so this is what healthy women are talking about, and they're diagnosed with breast cancer at this time. But you can see there's a bell-shaped curve, and certainly we still see breast cancer cases diagnosed in the 80s. And there are a small number of women who are diagnosed in the 20s and 30s. And one of the unfortunate things I can tell you is that there's really disparity. So I have focused with Ms. Medicine on gender disparity in care, but I can tell you that racial disparity is really a huge issue as well. And in the breast cancer space and in cardiovascular disease, African-American women get the worst care. And you can see here that mortality is higher in the non-Hispanic African-Americans. And you can see that 40%, there's a 40% higher mortality rate for African-American women to die of breast cancer in the United States. So real racial disparity as well. And we need to really address that as well. Okay, what I'm going to focus on and what I want you to leave here today is to remember to focus on heart disease symptoms or possible heart disease symptoms. Make sure you are addressing all of your heart disease risk factors, as what Dr. Stewart talked about. But I also want you to learn about or think about your individual risk for developing breast cancer. There's really a lot of emphasis about getting your annual mammogram. Every single woman, again, kind of knows that, 12% lifetime risk, 1 in 8, get your annual mammogram. But I want to just talk about getting your annual mammogram is not the same as preventing breast cancer, right? When you get your annual mammogram, that is a screening test to look for breast cancer that's already there. And my opinion and belief and my mission is to really try to shift the focus for women and say, hey, I'm a woman, I have breasts, I'm at risk of having breast cancer, but what can I do to actually prevent breast cancer, not just diagnose it with a mammogram, right? Because I don't want women to be diagnosed, I want less breast cancer. So how do we do that? So the future is precision medicine. It's precision medicine in a lot of ways. Many of you, I'm sure, know that the field of genetics is just exploding. In many, many ways, we're learning differences, even with the whole COVID pandemic, right? There's an understanding that clearly there's different genetic factors that play into why some people have a completely asymptomatic disease versus why some people have the cytokine storm and end up on a ventilator and die. And that there are factors that we are going to be able to learn how to understand better through genetics. In the same way, there's lots of precision medicine going on in the space of medication, right? So there's something called pharmacogenomics. Now, for many medications, you can do genetic testing to understand how you metabolize medicine, because of course we know that there's differences in how everybody responds to medication. And so this is the concept of precision medicine. And I want to tell you that we need to move into this space of precision medicine, and we are, when it comes to breast health. So on this slide, you see a group, 100, 1,000 women. And I want to make the point that every one of us is unique. Every one of us has different genetics. Everyone has a different family history. Everyone has different lifestyle factors. Everyone, is a different race, ethnicity, background. We are all completely unique. And so when you think about breast cancer, we're telling all women just to get their annual mammogram. And I want to ask you, does that really make sense? And I want to explain why maybe it doesn't make sense. And the future in this space is for all women to start to have a better understanding of what your risk individually is compared to that number that I told you, 1 in 8, or that 12% lifetime risk. Is your risk as a woman higher or lower? So is your risk 20% over your lifetime? Or is it 7%? Or is it 24%? Or is it 30%? Or is it 10%, right? And do we know this? Do we have a way that we can tell you this? And the answer is we do have models now to help women understand this risk, and we're frankly not doing it. And when you think about it, so if you look at all of these women on this screen, or you think of everyone on this call, and we're telling all women just to get their annual mammogram, when everyone's risk is different, does that really make sense? Should we be doing it that way? And I would argue we should not be doing it that way. And we're going to move into in the next several years, much more precision about specific guidelines for screening based on a woman's individual risk. And I want you to think about this in the context of heart disease. So Dr. Stewart did a great job presenting information about all of the risk factors and all of the things that women and men can do to lower their heart disease risk. And so you can see on the lower right there, there's something called an Ascvd plus calculator. This is something I do in practice all the time. I know Dr. Stewart does well also, where you can take your risk factors and calculate it and give you as an individual what your 10-year and lifetime risk of developing heart disease is. And we have guidelines about what to do with that information. Well, think about if we managed heart disease the way that we're currently managing breast cancer and mammograms, right? What if instead we didn't ever focus on risk factors? What we did is just told every person to have a stress test every year, right? Just get your stress test every year. And what that would say is, we don't really care about your risk factors. We're just waiting until you have a positive stress test and then you need your angioplasty or your bypass surgery, right? That doesn't make any sense. What we're doing with heart disease is we're working really hard to identify individuals who are at risk, so those individuals with their doctor can take steps to lower their risk to prevent heart disease. And that's what we should be doing with breast health and breast cancer prevention, and we're really not doing it yet, and I want to do it. So this is a patient, a very typical patient for me in practice. I still have a very busy clinical practice, and we could change the age here and make her 45, 55, or 65. It doesn't really matter because women come in and they're worried about breast cancer. So in this particular patient, and this is just one example I'm giving you, she's premenopausal, she's still having regular periods, she's done having her kids. Her mom had breast cancer at age 60, but her mother is still living, and she's worried about breast cancer. And she doesn't know what to do about it except get her annual mammogram. And so what kind of conversation do I have with patients? Well, in much the same way as Dr. Stewart talked about, talking about things that you can't change in terms of risk factors for heart disease, there are things that of course you can't change about your risk for breast cancer. So clearly you can't change your age, and you can't really change reproductive factors. And we know that puberty, your age of first menstrual period, your age at menopause, and your age at first live birth really impact your risk. So if you have early puberty or late menopause, or you have older age at first live birth, those things increase your risk of developing breast cancer, and you can't really change those. And then what about genetics? So women worry all the time, if you have a family history of breast cancer, but I want to point out here that 75% of women who are diagnosed with breast cancer don't have family history. Genetics only makes up about 25% of it. 75% of women, when they have that diagnosis, have no family history. So I tell women, if you are female and you have breasts, you are at risk of developing breast cancer. And so again, family history is important to help us determine what your actual risk is, but everybody is at risk. And what about breast density? So this is something that over the last several years, I've seen an increase in women being aware of the impact of breast density on risk and having a better understanding of their own breast density, but it's not across the board. So for you, one of the take homes for anyone listening, what I would say is I'd really like you on your next mammogram to look at the actual report and see if you can find these words, because it's now mandated that in your mammography letter, it will say negative. And what most women do is they see that it says it's negative, get your mammogram in 1 year, and they throw the letter away. In the body of the letter will be one of these 4 groups of words about density. It will say breast composition replaced by fat, breast composition scattered fibroglandular density, or heterogeneously dense or extremely dense. And you can see out of 100 women, about 10% have extremely dense breasts, about 35% of women have heterogeneously dense breasts, 45% of women have scattered, and 15% have been replaced by fat. And I can tell you what you want as a woman, it's the only place you really want to have fat is you'd really like to be in the replaced by fat category when it comes to breast cancer risk. And why is that? Well, 45% of women are in these 2 categories, these C and D, which are we consider increased breast density categories, and increased breast density increases
breast cancer risk. And what the density, and I didn't mention, is really describing, this is something only women can know on their mammogram. And it's a radiology, the radiologist scores it. You can see on these pictures, black is fat and white is glandular tissue. And so what these categories are taking into consideration is the percent of glandular tissue compared to fat. So the more glandular tissue you have and the less fat, that increases your breast density. And why is this important? Because women, that group that has extremely dense breasts, and again, you can only know this based on your mammogram, that doubles your risk of developing breast cancer. Women need to know that. And if you have heterogeneously dense breasts, you have a 20% increase in risk. If you have scattered or replaced by fat, your risk is actually lower. And these things we take into consideration when we're helping women understand their actual risk. And the next point I want to make is that there are things that you can change, right? So you can't change your genetics, you can't change your breast density. It's like the color of your eyes, right? Those things are really fixed, but there are things that you can do. And I want to just emphasize time and time again that for heart disease, we know that lifestyle matters. What I believe and what I see in practice is women don't really realize the impact of lifestyle on their risk of developing breast cancer, and it impacts it dramatically. So this is a really terrific international organization, the World Cancer Research Fund International, and they have great guidelines on their website. But you can see here from this table that they have is that the important things are maintaining a healthy body weight, physical activity, eating largely a plant-based diet with lots of fruits and vegetables, avoiding processed meat and animal protein, limiting your consumption of artificially sweetened drinks and high fructose containing drinks, and limiting alcohol consumption. And these are really all of the things that for breast cancer and heart disease, we should all be doing as women, and it's really important. And what do we know? And I think this, in the United States, where there is an obesity epidemic compared to European countries and elsewhere in the world, but obesity has an unbelievable impact, and I'm going to show you some things on breast cancer risk. So that's the first thing. But you can see here that if we could get women to have all of these healthy lifestyle habits, which is limiting alcohol consumption to 3 drinks per week, exercising regularly with a mixture of cardio and weight bearing, having largely a plant-based diet, and maintaining an ideal body weight, we could prevent about 33% of breast cancers, or 76,000 cases per year. That's a huge number. That's preventing breast cancer. That's not looking to find an imaging strategy to see tumors earlier that are already there. This is talking about prevention, which is really what the goal should be, right? Preventing women from getting breast cancer, not just identifying it earlier. And this is a slide I like to use to just describe what's happening with mammograms. So mammograms, and I don't want to minimize the importance of mammograms. Everyone on this call should still be getting their annual mammograms. Mammograms are very, very important for detecting breast cancer, and size matters. We need to detect breast cancer early. But the problem is we're missing cases of breast cancer with mammograms. It's like we're detecting the tip of the iceberg, but there's all of these cancers that we're missing on mammogram. And how do we know that, and why do we say that? Which is, when you look at the size of tumor diagnosis, you can see that only 55% of breast cancers that they're diagnosed today are diagnosed under 2 centimeters or 20 millimeters, right? And that we consider early stage disease. But you can see it's really 40 to 45% of cases are diagnosed above 2 centimeters. And you can see what I wrote here is that breast cancer, it takes time. Breast cancer is different than ovarian cancer. It takes time to grow from 1 centimeter to 2 centimeters. So if you have a 2 centimeter tumor or larger, you know that that tumor was there on your prior mammogram a year ago and it was missed. And so again, when women are diagnosed as late stage, it proves that mammograms are not enough and they're not perfect. And we know that. Now, that doesn't mean we shouldn't have them. It is the best screening test that's available. With widespread and appropriate adoption of mammography, we have seen earlier diagnosis and improved survival. It's really important, but it's not enough. And I'm a great example of why it's enough. So I didn't tell you at the beginning, but I am now a 6-year survivor of breast cancer myself. Those 2 pictures there were taken about 6 months apart. I had a very large tumor, multifocal disease, and I was very compliant with getting my mammograms, and I had no family history. And at the time I was diagnosed about 6 years ago, we were really coming to understand much more clearly the impact of breast density, and really starting to understand that we needed to do a better job with these risk assessment models, because women like me who had extremely dense breasts but no family history was at elevated risk that I really was not aware of in terms of the magnitude of risk, and was not doing what I should have been doing in terms of getting more aggressive screening because my risk was elevated. And so again, these 40% of women who have their breast cancer diagnosed late, we should be doing more. And one of the important things is to make sure that we're helping women understand their risks. And so if we go back to Catherine, right? So she's 45 and she's healthy, and her mother had breast cancer, and she's worried understandably about her risk of breast cancer. How can we as clinicians, and this is what we're doing in our Ms. Medicine practices, we're working very hard to have a whole program, which we can talk about, to really give very specific information to women about their risk, and to do a better job identifying women who meet criteria for genetic consultation and genetic testing, because they may carry a gene that puts them at substantial risk in the hereditary breast and ovarian cancer family. And we know we're missing these women. We are not identifying women who are at high risk well enough, and we are missing women who really need genetic testing, and we're not doing enough testing. So there's lots that we can be doing in practice, and this is one of the exciting things about working with someone like Dr. Stewart in Naples, and what I'm doing with Ms. Medicine in terms of building this network of women's health clinicians across the United States. And so if we look at Catherine, there are algorithms, and this is what I do in practice. This is what Dr. Stewart does now in practice. It's a model called Tyrer-Cuzick. And many of you may know from the whole COVID pandemic that there was lots of modeling. There still is modeling done that lots of the pundits and news reporters talk about in terms of modeling what the projections were going to be for death rates and for number of ICU beds we were going to need and the amount of PPD. So these models are really, really valuable when you have adequate information that you can put into the models. And only in the last couple of years have we been able now to add breast density as one of the things that the models take into consideration. So these models that we use, this Tyrer-Cuzick, has become much more accurate. So in this case, I'm going to tell you, so Catherine, I told you she's 45 and she's healthy, and she has a first-degree relative, her mom, with breast cancer. And when I put her data in, if I say that she's 125 pounds and she has scattered breast density, with that first degree relative, her lifetime risk is 19.3%. And I'll tell you what that means in a second. But I want to go the next slide and say, if the only thing I change on that Tyrer-Cuzick model when I enter all the stuff in the computer and I hit calculate, is I change her breast density to extremely dense breasts, which is what mine were. You can see extremely dense breasts and a first degree family member with breast cancer puts your risk definitely above 20%. And in this case, this woman's lifetime risk is almost 40%. And this is information that this woman needs to have, because if her risk is above 20%, she should be getting an annual breast MRI in addition to her mammogram. And I can tell you that 45-year-old women who are healthy, they're just on childbearing, they're not seeing doctors very much. They don't have this information and they don't know this uniformly. And this is a huge gap in our care of women. Oh, sorry. And if I do one thing and I make her 180 pounds instead of 125 pounds when I plug this, and I will tell you in the exam room with patients when I do this, I play around with the data. I show them, okay, if your weight is this, if we change your menopause to this, if we change your first pregnancy to this, if we change, now we make you also have a sister with breast cancer, and I show kind of the impact of this. But the one thing that women don't know is the impact of obesity on breast cancer risk. And you can see that in this case, if I just change the modeling, I go from 39% risk of developing breast cancer to 48%. So the first thing I'm doing with Catherine, if this is Catherine, in my office, is I'm absolutely saying, in addition to getting your annual mammogram, you need an annual breast MRI, but we need to work on weight loss, and we really need to talk about exercise, and we really need to talk about alcohol restriction. So the take homes really are for all women, right? Doesn't matter your risk. Body weight matters. Maintain a healthy body weight. Limit your alcohol intake in the breast cancer space. And we can talk about pro con with heart disease. And if glass of red wine a day is good or not. But in the breast cancer prevention space, it's less than 3 drinks per week. And I have a colleague, an amazing colleague at the Mayo Clinic in Jacksonville. Her name is Dawn Musalam. She's a big researcher in the diet, impact of diet and alcohol on breast cancer. I went to a professional meeting with her. She's an amazing speaker. And I walked away there as a breast cancer survivor saying I shouldn't drink any alcohol at all because there's definitely an association. Really, exercise is important, and moving to a plant-based diet. And I tell my patients, don't do what I do because I don't have a completely plant-based diet at all. And I try to make subtle changes. I have really personally moved to less animal protein and more fruits and vegetables. And that's what I talk to my patients about as well. And remember the number, 33% of breast cancers, not all breast cancers, could be prevented if we did a better job with lifestyle. So lifestyle really matters. Oops. And then quickly, I want to spend a couple minutes because this is my other area well, I have many, but I'm really passionate about the menopause and hormone therapy space. And when I talk to medical students and other clinicians, because I do a lot of education of other providers as well as consumer education, my big statement is that the journey of hormones has defined my professional career. So I finished my residency and started in practice in 1990. And in 1990, from lots of good data that were there, we believed that hormones were preventing heart disease in women. And we were prescribing hormones. I was prescribing hormones in the first 20 years of my practice to all of my patients because the belief was we're preventing heart disease and that the net benefit of hormones on heart disease was much higher than any concern about breast cancer risk. But many of you all know that 2002 was a huge year and the hormone journey turned on its head because of a large study that came out called the Women's Health Initiative. And this was a different study than the data that had been done before. This was a study to look at the impact of hormones on outcomes. The interesting thing, in hindsight, the study was done with a very diverse group of women. So it included lots of older women who were very remote from menopause. And this is one of the things about big clinical trials, that it depends on what your study population is, how you interpret the data. But I can tell you that the impact of the WHI in 2002 was that doctors, and particularly primary care doctors, got the message, and patients got the message that hormones are bad. And everybody stopped prescribing them. Primary care doctors to this day, when I lecture, are very confused about the data and won't prescribe them. And really, we've learned so much in the 20 years since the Women's Health Initiative that I really want to talk about, but it's still very confusing for doctors and understanding both the risks and the benefits. What we now know from long-term follow-up of the data, when it was originally came out, it said there's a 25% increase of risk of breast cancer and a 25% increase in heart disease. And that led to everybody stopping hormones. What we now understand in the follow-up is that that's not really true, that there really is no difference in cardiovascular disease or coronary heart disease mortality, and no difference in all-cause mortality in 18 years of follow-up. But if even though we know that now, I can tell you that even currently, the pendulum has not swung back, and that doctors really are still very fearful of hormones. And you can see we went from 90 million prescriptions per year for hormone therapy and about 20% of women who were being treated to now just 2% of women, a 90% decline. Whoops. And is that right? Well, what we now know, and I would tell you, is the pendulum has gone too far. So like many things, we go one way and we go all the way the other way, and we've got to find some place in the middle. And I can tell you, find some place in the middle based on our understanding of the data. And what we know now is that only 30% of women with severe hot flashes who are excellent candidates for hormone therapy are even getting treated, which is just unacceptable. And I see these women in practice all the time suffering. The other thing to note is what's terrible is that postmenopausal women after menopause, 88% of them by year 8 are having sexual dysfunction. And I can tell you that these women are not getting appropriately cared for. And it's the leading reason that women stop having sex after menopause. Now, there's lots of reasons to stop having sex, but I would argue that not getting appropriate care is not the right reason to stop having sex. And what we know, despite lots of effort in the women's health space, with lots of outstanding medications to just treat the atrophy, the vaginal atrophy that develops as a result of menopause, that only 7% of women are being treated. So again, this is a big failure of what we're doing in the women's health space. But I want to bring it back just to heart disease to make a point, which is Catherine that we talked about at 45 is very different from, let's say, Joanne, who's 75 when it comes to thinking about hormones. And I want to make the point that we now clearly understand from data that there is a window for estrogen, which is in younger women, 50-year-olds, 45-year-olds, 52-year-olds, 55-year-olds. The impact of hormone therapy at preventing cardiovascular disease in those young women is real. It prevents cardiovascular disease. And in fact, the American Heart Association just came out in November now with finally a very clear guideline to make this very clear. The difference in giving estrogen to Catherine at 45 versus giving it to Joanne at 75 in terms of what it does in terms of heart disease risk is very different. And I want to point out, this is the progression of cardiovascular disease over 25 years. Women, by and large, do not start forming plaque in their arteries until after menopause. It's the reason that women tend to be older when they have their first event. And this process takes a long time. Again, with the exception, it's faster if you have a family history, it's faster if your cholesterol is high, it's faster if you smoke. But in general, this is a progressive process. And what we know is that in younger women who really have no plaque, so these are the 50-year-olds when they're going through menopause, when we give them estrogen here, it has one effect. If we give estrogen to someone who's 75 and has plaque that's already formed, it has a different effect. And so we know that the data now is very clear that younger women, it is preventative, it's beneficial in terms of heart disease risk to give women hormone therapy, and it causes harm in older women. And this is why having a doctor who knows the data about menopause, who can really talk about hormone therapy for the right patient for the right amount of time and what impact that has on both heart disease and breast cancer risk is really important. So the guidelines now say that hormones started within 10 years of menopause reduces heart disease risk by 40% and reduces death by 30%. So the take home for all of you is hormones in the appropriate patient are not all bad. And so in 2020, we use hormone therapy for symptoms related to menopause. We don't use it for anti-aging or disease prevention, but in younger women, we know hormone therapy lowers heart disease risk, decreases dementia, prevents bone loss, and lowers mortality. Now, there's lots of these bioidentical compounded pellet hormone centers and lots of people doing pellets. You do not need pellets to have an FDA approved bioidentical option. I do not believe in pellets and do not do pellets because there are approved, FDA approved bioidentical options that are dose appropriate and that are safer. And so don't exclude hormones. If you're a woman going through menopause, talk to a doctor that actually knows the data well enough so they can have a complete picture of you and you can be involved in shared decision-making. And then finally, in the last second, I just want to tell you the world is exploding right now in the venture capital, private equity companies starting up. There's millions of them. This is a smattering of them in what we're calling the femtech space in 2020. And there's lots of work being done in that space, as well as in women's health devices and procedures and products. It's really exploding. And as a consumer, I just want to make sure that you're aware that you're very thoughtful and careful. Because one of the things that is happening, and all of you know this, is that with social media and marketing, celebrities have become healthcare experts, and there's a lot of bad information out there. And so you really have to be a very smart consumer. And I really encourage you to have a doctor who's practicing evidence-based medicine, who knows the women's health space, who can answer questions for you and help guide you. Because not all that glitters is not gold. And I know this very clearly, right? You can have a well-funded marketing company with $100 million a year marketing budget, and you can sell with social media just about anything to anyone. And there's a lot of things out there that are dangerous, that are really well marketed by these celebrity spokespeople and that don't have data to back them up. And women are vulnerable. So please, I encourage you to be really a good shopper and a good consumer. And remember, the other thing is there still is implicit bias in care. Doctors, it still exists, and women are still, we know, not taken seriously many times. And there's really not adequate understanding of the differences in the way disease presents in women and men. And I will tell you, heart disease is a great example of fundamentally the disease is different in women. Women have smaller heart arteries, they form plaque differently. And what we know is they respond to cholesterol medications and aspirin differently, that we are applying data that was developed in men to women, and we're learning that the data doesn't apply. The aspirin data is really, really important. It was all done in a study in men. If you can imagine the Physicians' Health Study, of which my father was a participant in the 1980s when I was in college, that data was 26,000 male physicians across the US who were given aspirin versus placebo to see if it had an effect on preventing that first heart attack. There was not one woman included in that study. And we applied the data to women, and PS only now in, where we are today, now 40 years later, do we understand that aspirin in women has a different effect in terms of risk benefit profile than it does in men. And we never even considered that. So we have a lot of work to do here. So please advocate for yourself. One of the reasons I'm so passionate about consumer education is because I believe the only way to improve care of women is not just through forming this network that I'm trying to do in clinician education, but it's also through educating and empowering women to really be better consumers and to advocate for themselves with their clinician. And if you feel that your complaints are not being adequately addressed, I encourage you to get a second opinion. And I will end there, and I think we would happily take questions. Thank you very much for your attention. And again,